Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Catherine Coombs from UCI Health and Dr. Toby Eyre from the University of Oxford. They will be discussing their choices of several notable studies presented at the recent 2023 International Conference on Malignant Lymphoma on the use of BTK inhibitors in mantle cell lymphoma and the associated potential clinical implications. This episode is part of a larger educational program titled Targeted Therapeutics in CLL and MCL, Applying Emerging BTK Inhibitor Therapy Data to Practice. For more information on the experts, along with a link to the complete program, including a downloadable slide set and expert commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Welcome to the 2023 Global Conference coverage updates on BTK inhibitors in CLL and mantle cell lymphoma. My name is Dr. Toby Eyre. I'm a consultant hematologist in Oxford in the UK, and I'm delighted to be joined by the Associate Clinical Professor Catherine Coombs, who works in UCI Health in California. Welcome, Catherine.
This is our part 2 podcast related to the summer congresses, and I'm Dr. Callie Coombs at UCI Health. We are going to be speaking about mantle cell lymphoma on this half of our series. And so with that, I'd like to first ask Toby, what is your, before we jump into all the new data, what is your general approach for treating mantle cell lymphoma in 2023? And what factors weigh into it, such as patient age, fitness, goals, etc.?
Yeah, thanks, Callie. Well, we're still in an era where we generally divide patients up according to fitness for autologous stem cell transplant. Although there's been some recent data challenging that approach, that still remains a standard thing to do. So immunochemotherapy is generally still a standard of care in younger or older patients, but the intensity and the consolidation strategies differ according to age and fitness. So typically those 65 and younger have a cytarabine and rituximab-based induction followed by a autologous stem cell transplant and rituximab maintenance. Older patients, there's a variety of immunochemotherapy regimes that can be used, VRCAP, R-CHOP, R-bendamustine, each of those often followed by maintenance therapy. So that's the standard approach that's available at present.
All right, great. And so the first study we're going to delve into is a phase 2 study by the GELTAMO group. This is their 5-year update on first-line ibrutinib plus rituximab, specifically enrolling patients with indolent MCL. And so in talking about this, could you tell me first, what is your standard of care in these patients? And then what is your take on the data presented on this trial?
Yeah, thank you. So indolent mantle cell lymphoma generally is observed. I would say there's broad consensus that patients who are asymptomatic, who don't have high tumor burden with low Ki-67 can be potentially observed in routine clinical practice. Although there's still a relative sparsity of data around how these patients perform over a long period of time. This study looked at the introduction of, as you mentioned, ibrutinib given at standard mantle cell lymphoma dose for 560 milligrams once a day, alongside rituximab. So this is essentially an early intervention study in mantle cell lymphoma, taking indolent forms of this. Now, one of the nice things, one of the interesting things about this study was that patients were able to stop if they obtained MRD negativity. And the primary endpoint was complete remission after 12 cycles. And we've seen this data presented before, and this was long-term data, nearly 60-month follow-up data. These are generally younger patients, pretty much all had lower risk features, as is expected given the patient profile. And the long-term data suggested that response rates were very good. And importantly, about 2/3 of patients were able to discontinue ibrutinib due to undetectable MRD attainment at 24 months. So conceptually, this study is interesting. Of course, this is non-randomized data in patients who might not otherwise, one could argue, need treatment. And so this really needs to be considered in that light, at least. One of the issues here in the study was there was toxicity seen with ibrutinib. About a quarter of patients stopped due to adverse events. About 14% actually stopped because of drug-related adverse events, and a small number of patients required discontinuation. But then the final thing to say is actually if you took some of the small numbers of patients with particularly high risk disease in this study, there were early events that did occur. And so those with, for example, TP53 mutations that were found at a later point, it doesn't look like their responses were particularly durable. Those with high risk MIPI, again, the PFS events did occur in that group. So certainly an interesting theoretical option. You can stop therapy in about 2/3 of patients at 2 years, and the long-term median progression-free survival of 72 months, 5-year PFS of 80% look good. But of course, these are low-risk patients. So we really need some randomized data in this setting.
Understood. And I have one general question for you related to this. We use a lot of MRD testing in CLL. In mantle cell lymphoma, I know a good portion of the patients enrolled were leukemic non-nodal. And so, of course, there's a good amount of disease in the blood. But for the portion of patients who did not have a leukemic presentation, I noticed that the MRD testing was via peripheral blood. Is that something that's done frequently in mantle cell lymphoma? And is that always helpful? Or are they monitoring like via cell?
It's a great question. So something called Euro MRD was used, which is an ASO qPCR method. There were some patients that had NGS. I think in mantle cell lymphoma, there's still a very big open question about how best to assess patients according to MRD. There's certainly in different studies, different techniques that have been used. And I think the jury is still out as to whether one should use flow or NGS or PCR-based technology. So yes, that's a short answer to a potentially very long debate. But internationally, there isn't consensus, and that is a little bit of a problem in mantle cell lymphoma. Obviously, CLL is just so much easier because you can do flow, and the consensus is sort of easy to obtain there. But yeah, that's how things stand at present.
All right, thank you. So the next abstract I would like to discuss is the one by the MD Anderson group looking at acalabrutinib with rituximab as a first-line therapy for older patients with MCL. So what are your thoughts on this one?
Yeah, so we've seen the MD Anderson perform a phase 2 study before with ibrutinib and rituximab. And actually, although response rates were very good, there were concerning signals of cardiac toxicity, particularly atrial fibrillation, hypertension. Quite a few patients out of their previous study of 50 patients stopped because of toxicity. And so conceptually, the idea here is to replace the ibrutinib with a well-tolerated second-generation BTK inhibitor that, at least in other disease entities like CLL, has shown a more favorable safety profile. It took older patients, so those 65 or older, good performance status. They received what was described as cardiology clearance in this study, which basically means I think they had a lot of cardiac tests and had a very kind of pristine cardiac function before going in. And patients receive rituximab up to 2 years, and then continuous acalabrutinib delivered at standard doses. And these were a relatively low-risk group of patients. They weren't super low risk. They weren't designed to be, for example, indolent patients like we've just discussed. There were a small number of blastoid pleomorphic patients. There were 12 patients in the 50 that had a TP53 aberrancy. And acalabrutinib plus rituximab was very well tolerated with very high response rates in this study. And with a median follow-up of 17 months, the 2-year progression-free survival is 92%. So really excellent results. Now, of course, this is a fairly selected phase 2, modest size patient population delivered at a single center. And so we certainly need to see the applicability of this combination in a larger number of patients across a number of centers to get a better feel for it. But certainly these early results are very encouraging.
Great. And so the third presentation I'd like to discuss relates to pirtobrutinib. And so, of course, we have discussed this already in the CLL podcast. And related to MCL, it's been presented, the Pirto and covalent BTK inhibitor pretreated MCL. It's an update to this subgroup analysis from BRUIN with at least 3 years of follow-up from start of enrollment. So I'd love to get your take on the study results and application to your practice. And obviously things are a bit different in the US because pirtobrutinib is already FDA approved now as of January 2023, not yet the case over in Europe and here in the UK. So please give me your thoughts on this one.
Yeah, thanks, Callie. So we've seen results from the BRUIN study previously across a variety of histologies, and we've seen pivotal data from the primary analysis set now published in the JCO just recently, 90 patients who had received a prior covalent BTK inhibitor and had more often than not been exposed to immunochemotherapy as well. So quite a heavily pretreated group of patients. Now, we've seen the response data previously, as I mentioned, published from this data set, and this was again presented in this abstract. So in 90 patients with a median of 3 prior lines of therapy with high-risk features, the response rate was nearly 57%. There were also some BTK naive patients in there with higher response rates, up at 85%. And the median PFS across the whole cohort was 7.4 months. One of the very intriguing aspects to this agent is patients who respond to it actually have very durable responses, considering the clinical use in the patient pathway of mantle cell lymphoma. These are heavily pretreated patients, and the median duration of response is about 1.5 years, which is an intriguing finding. We need to sort of understand why that's the case. And then one of the other important findings from this update was patients who received pirtobrutinib seemed to do just as well if they responded, whether they had a p53 deletion or didn't, or whether they had a high Ki67 or didn't. So 30% was the cutoff in this study. And we've certainly seen with covalent BTK inhibitors, both of those factors are quite strong adverse prognostic features with, for example, pooled analysis of patients who've received ibrutinib in the past. So slightly longer follow-up in terms of the overall data set, but some of these sub-analyses were certainly interesting. And as you mentioned, Callie, this is now approved, I think, 3rd line and beyond in the US in patients who've received at least a prior covalent BTK inhibitor. And it's received, I think, conditional favourable opinion, I think is the phrase, from the European Medicines Association, which may well mean that we see formal approval later in the year. And of course, it's important to see whether the approval is, again, sort of 3rd line and beyond, or whether it's broader, because who knows, it may be broader in terms of relapsed refractory mantle post-covalent BTK, which of course is then relevant for sequencing of therapies when you think about CAR T-cell therapy and other agents in development like bispecifics. And the final thing to say about BRUIN is the safety. We talked about safety profile of other BTK inhibitors in CLL earlier. Certainly the safety data from the BRUIN study, overall patient population receiving pirtobrutinib, but also the mantle cell lymphoma cohort looks very favourable, very low rates of hypertension, atrial fibrillation, discontinuations due to toxicity, etc. So certainly looks like a good agent to potentially move forward in the treatment pathway in mantle cell lymphoma, and that's being tested in a randomized trial, but also to be combined with other therapies, both in mantle cell and potentially other disease entities moving forward.
Yeah, you actually picked up on what I was going to mention. So the majority of this cohort had prior covalent BTKIs, but there were about 14 patients who were covalent BTKI naive. And when you look at the waterfall plot, it's so striking how excellent their responses were. And so I definitely think that gives me confidence in the ongoing trial. Of course, we'll have to wait to see what those results show. But the phase 3 trial in mantle cell is stacking pirto against investigator choice of either ibrutinib, acala, or xanu. And so that'll be a trial I'm eagerly awaiting the results of. I think the safety profile certainly is very attractive. And so hopefully the efficacy can stack up favorably as well, but we'll have to wait on those results to see. And so with that, that concludes our second podcast related to the summer congresses. I thank you all for your attention. And of course, thank Toby for doing this with me. I hope you all have a great day.
Great. Thanks, Kelly. Thanks for listening.
Thank you very much, Dr. Coombs and Dr. Eyre, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Targeted Therapeutics in CLL and MCL, applying emerging BTK inhibitor therapy data to practice, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.